Oh, we just got an updated message that the session will be starting in 15 minutes. Okay. Oh, there we go. Never mind. Yeah, we'll be starting in 1 minute. Clevon, can you please make me co-host of the session? And we're going to be starting shortly. I'm sure participants are just leaving the other sessions, so we'll probably give it 1 minute, and we will begin with me making just some statements on housekeeping items, quickly introducing each one of our panelists just by name and title, and then we'll hand it over to Kent.
And Mike, as I said, Jularina is still listed as an attendee as opposed to a panel, so I'm not sure if she can speak.
Yeah, I think shortly I'll be made co-host, and I'll be able to change her.
And you can do that.
Her role. Yeah. Thank you. Thank you, Clevon. Okay. There we go. Okay, Jularina, can you hear us? All right. Thank you. I think we're just waiting for Jularina to join as panelist. But in the meantime, I think we can get started. I will have my camera on for just a moment as we begin, and then I'll be turning this off. Well, good morning, good afternoon, good evening, everyone. My name is Michael Serra.
Buenas tardes, me llamo Michael Serra.
Oh, 1 second.
Un momento.
Okay. My name is Michael Serra, and I'm the local partner transition advisor.
Michael Serra, y soy el asesor local.
I want to thank you all for joining us for a session today on
Agradecer a todos ustedes por unirse a esta sesión titulada Poder de los peces, de las poblaciones claves.
I'm trying to mute. Okay. Can you hear me now without the background noise?
¿Me escuchan?
Yes. All right. We are privileged this morning to be able to hear from 4 of our partners on the forefront of KP engagement, as well as our very own senior technical advisor for key populations. Before moving on to making introductions, I wanted to review
a hacer la presentación, quiero recordarles un par de cosas antes de comenzar la sesión. Quiero pedirles a todos que por favor silencien los micrófonos cuando no estén hablando y solo los haciendo la presentación.
If you would like to ask a question, please feel free to just type it in and in your preferred language in the chat box on the right side of the screen. And we will be referring to them throughout the session and at the end of the session in our designated Q&A portion. Please feel free to engage with each other on chat, because that is really going to be an important opportunity for you to interact with the panelists and with each other. You can also take some time to explore the Pioneer platform. There are some functions to engage, invite folks, both panelists and participants, to conversations, to chat, to learn more about what they're doing. You should also be able to listen to this presentation in English, French, Portuguese, or Spanish. You can find and select at the bottom of your screen the interpretation icon and choose the language of your choice. You can also mute us, the presenters, if you only want to hear the interpreted content, if that is easier for you. Also, finally, you will be able to find this presentation as well as yesterday's presentations on the platform. Yesterday's presentations are available today. Today's presentations will be available tomorrow. So you can review any of these presentations at your leisure. And finally, as a way of an introduction on your end, I'd like to ask each of our participants to write in your name, your title, and your organization in the chat box, just so we know who's joining us and a little bit about where you're joining from. Great. So I'm going to move on to introductions. On our panel today, we have Susana Lungo, Regional Executive Director of the Pan American Social Marketing Organization, or PASMO, based in Guatemala. Jorlarina Timbo, Senior Advisor for Community Engagement at IntraHealth, Namibia. Tifarangi Visalona Timbo, Visalona, Chief of Party for the Protect Project at the Center for the Development of People, or CEDEP, based in Malawi. Michael Akanji, Key Populations Advisor at Heartland Alliance, Nigeria. And Kent Klindera, Senior Technical Advisor for Key Populations at PEPFAR here in USAID. Sonia Rao, Program Assistant with the Key Populations team, will be supporting us with administrative functions. Now, without further delay, I will hand it off to Kent Klindera, who will share a brief overview of our programs.
I think I'm muted. Great. Thank you, Mike. Welcome, everyone. So glad you could join us today. And once again, if you can introduce yourselves in the chat, that would be very helpful for us, those of you that are not presenters. We've got a nice panel. Most of our folks are rather new partners, local partners. And so I think this will be very informative. We're not going to have very formal presentations. We thought it'd be better just to have a number of questions that folks can answer and sort of have a discussion about it. And then we're going to open it up. If folks do have questions, we encourage you to use the question and answer function or the chat function. And so, Mike, if you can extend the next slide. What we thought we'd do is go through each of the projects briefly to give you a bit of an explain. Oops, being told. Can you all hear me?
Yes, we can hear you.
Okay. Yeah, so if we can go through, bring the slides back. Perfect, thank you. So if we can go to slide 2, basically just a little explanation of each of the projects. First, as Mike said, Tifarangi is with us from CEDEP. CEDEP is a new local partner as of in 2020. They are actually a KP-led organization working on human rights, health and human rights. Like most of us are working around zero HIV infections, zero stigma discrimination, and zero HIV related deaths. If we can go to the next slide. CEDEP has a long history of being funded under PEPFAR. having been supported initially under the EBT project with PSI. Like a lot of KP programming, originally sort of started as a prevention project, but really has shifted into a full cascade of both prevention and treatment programming. But you can see have worked under linkages for many years, also under EPIC, and this year actually transitioned to be a local partner directly funded. But they also have a number of other donors, including Elton John in the past, including UNICEF and many others. So this is set up, and Tifurangi will speak from that perspective. Next slide. And so our next speaker is Michael Akanji. Michael is with the KP Care 1 project, part of Heartland Alliance. They're, as a project, as an organization, have led for a long time in Nigeria around KP programming. Heartland Alliance just recently transitioned to be a local partner. And so we used to work with Heartland Alliance International in Nigeria. We're now working with Heartland Alliance Nigeria. But cross-cutting principles under KP Care 1 are that the response is KP-led, that gender is vital to the programming, that they work a lot with KPs, so they're dealing with a lot of trauma, and really their mental health programming is trauma-informed. They've got a strong harm reduction program, and also recognize equally important to health is human rights and access to justice. They're working in 3 states currently, and as I said, they transitioned recently back in December 19 to be a local partner. So our next slide. Our next speaker is Susie from POSMO, and POSMO is the Pan American Social Marketing Organization. Once again, a similar history of really initially being a prevention program. They're a social behavioral change communication strategy organization, but really have shifted more so also to deal with treatment issues. We can go, POSMO is part of the PSI network globally. So we can go to the next slide because we've got a bit of background. Susie's based in Guatemala, but they're working in 5 countries in Central America. Once again, our 95-95-95, working with MSM, with trans folks, with people living with HIVs, and with the sexual context of and partners of people living with HIV. Can we go to the next slide? And our last speaker is from Namibia, is Jolarina Timbo. Jolarina is with the KP STAR project, and similar to Heartland Alliance, they started as a IntraHealth International, but this year transitioned to be a local partner, IntraHealth Namibia. This is a similar project in that it's a both prevention and treatment program. They work through drop-in centers. The project actually works with a treatment partner, Wellfish Bay Corridor Group, as well as 3 KP-led organizations and networks, Rights Not Rescue, Rights for All Movements, and Wings to Transcend. And so as you can see, all 4 of our speakers come from local partners who are doing KP work. We've selected them all based on success that we're seeing this year in a lot of reaching their targets. And so without further ado, what we thought we'd do is just have a discussion, asking some questions, and hopefully in the chat, you all, or in the question and answer, you all be asking us some questions as well. So if I can move to the next 2, I can move up 2 slides because it's leading us to our first question. Our first question is about, so the next slide. Our first question is really about COVID. And what we thought we wanted to hear is, the KP programming that you're working on, how have you been able to successfully respond to COVID restrictions, and what current needs still exist? And so I think for this one, we're going to hear first from Susie, if you can answer that question. And Susie, if you turn your camera on, that'd be great. Thanks.
Yeah, thank you. Can you hear me?
Yep.
Okay, thank you, Kent and Mike, and good morning to everyone. Regarding the adaptations we have made, it is important to note that the program that we implement in Central America is a prevention program focused on testing and linking. And we work in partnership with the private sector, with private laboratories. So COVID-19 restrictions limited access to testing and linking significantly, because not just because of the lockdowns, but curfews, lack of public transportation, closing of some health services providers, shift of public services entirely to COVID-19, at least in the first several months. So that is part of the context. Our program was already conducting online outreach and referrals with MSM and other risk populations through our cyber educators strategy. So one adaptation included the entire shift to cyber education, while field-based activities were suspended. More support using social media. We made adaptations in our social media strategy and in the content, and developed specific messages for people living with HIV and COVID-19. Another adaptation was negotiating with our private laboratory partners to offer at-home HIV testing services. We continue sending referrals, but as transportation was limited, this was an effective alternative. And to ensure linkage, instead of in-person accompaniment, we shifted to virtual accompaniment, which included coordination with public care clinics and other partners to ensure appointments and access to treatment for more than one period. Although we are not an adherence program, people know our social media channels and cyber educators, so they were reaching out to us first to obtain information about how to obtain their treatment. And in some countries, we were able to cover private transportation costs to linkage, as public transportation was suspended for many months. And finally, we were allowed to realign some funds, and we developed a COVID-19 prevention campaign in support of ministries of health in the region. So we coordinated with them and with other partners and organizations. And we collected the data on COVID-19 indicators as we participated in a national survey, a public opinion poll in the 5 countries in Central America. It was a telephone survey. And this helped us identify the barriers to prevention behaviors, but also show the need to work on psychological effects of the pandemic, depression, disruption in sleep. And the survey also confirmed stigma and discrimination towards individuals who are infected with or at risk of contracting COVID-19, health personnel, and migrants and returnees. So especially with migrants and returnees, we developed a guide including next steps on critical routes for COVID-19 and HIV in coordination with the Ministries of Health and migration offices. So overall, the campaign focuses on how life has changed and how people can adjust together as a community, and including messages, prevention, mental health, stigma and discrimination, in targeting not only key populations, but also other priority populations, such as indigenous, migrants, returnees, and other vulnerable populations to COVID-19. So what else, what other needs still exist? I would say that many restrictions remain in place. It will be important for our program to make these adaptations more permanently, at least in the medium terms. And communication efforts should continue, especially in areas such as mental health and stigma and discrimination.
Sure, Susie, I'm hearing that a lot from programs, that moving to a virtual space has actually been quite efficient. And if there are ways for us to continue that and sort of learn from this, I think is very helpful. Yeah, thanks. I think actually Michael is gonna, Michael Akanji is gonna also answer this question. Mike, do you wanna speak to how you all have in Nigeria? Yeah.
Thank you very much, Kent. For us at Land Alliance, basically our program at the community level, we work with KP-led community organizations. And the way the structure is at the community level, it's that at each of the community, we have the people we call outreach community focal persons. That's CFs, that's what we call them. And these people at the community provide virtually all the services we do, with the exception of the biomedical part of the services. And when you now talk of responding successfully to COVID restrictions, at a program, because we are largely more of community-based, so one of the challenges we had with the restriction was that the community workers were not assigned their pass. They were not, by the government, they were not given that pass as essential workers. That was a challenge first when the COVID restrictions started. But as time goes on, through our advocacy with the government in the states we work, we're able to get these passes for some of them, not all. And the adaptation we've been able to make based on this restriction, we've been able to move further to have what we call community focal points. These community focal points are healthcare workers that are residents at the community that can provide services for KP community at the community level. That is also working with paralegals at the community level, because we have community-based paralegal. We also have community-based mental health persons. So these people are closer to the community. So the restriction of movement does not really affect them because of COVID, and they are able to provide services at that point in terms of interpersonal communication. Then apart from that, we've also been able to adapt virtual communications with the community. Because we work with a network of KP-led community organizations in the state we provide services. These community organizations, through our technical support, we're able to start providing community-based health education for key population, mental health education, and even COVID prevention services through them. And some of them too, because of the vocational training that we've been able to do with them, some of them have been able to also produce face masks that are also shared to the community too. And apart from that too, as an organization, we also have the toll-free lines, which became very, very useful during this time. Because if you look at the poverty level and the economic level of the KP community that we serve, it's very low. So as a result, telling them to be online, which might be quite expensive, so we provide a toll-free line where they can call free, and we provide them services. And you remember, we have this community focal points where, for refills, apart from those that we have done multi-month dispensing for either for 3 months or for 6 months, in order to retain them in care and also to encourage their adherence, we still provide remote support for them through our toll-free lines. And in modifying our peer education manual, we've also introduced aspect of COVID prevention services in our peer education manual that we've also upgraded. And in responding to all this, we've been able to see that despite this, the need that still exists, it's internet penetration is still very low among some KP groups. For example, persons who inject drugs, internet penetration is still very low. So that need still exists, that it's very important that we still go on with our community-based programming in order to be able to be providing services for them. Thank you, over.
Great, thanks, Mike. Actually, and I had Jo Lorena who also wanted to respond to this question. Jo Lorena, you with us?
Yes, Ken, thank you. Let me just switch on my camera.
So Juliana, I'll be honest, something I've heard from a lot of KP programs also is that especially sex workers have been challenged by COVID about livelihoods, yeah? And also I think the struggle I've heard from a lot of KPs, you know, when folks sort of shrink back to their families for support or their communities, whereas a lot of KPs often are rejected by families or ostracized. So I'm curious if that's something you all are struggling with in Namibia, sort of the livelihood concept, especially for sex workers, as well as just everyone struggling on finding support.
Yes, absolutely. Can you see me?
Yep. Mm-hmm.
All right. So, as a program and with our partners on the ground, that has been the case where a lot of livelihoods for sex workers due to the restrictions that were imposed when COVID hit was really, really detrimental, right? So people were struggling to make ends meet. People couldn't even, get essentials and so forth. And during that time when COVID was severe, it was really, really crucial that you have all your essentials, that you've got all your the daily needs that you need as a person to be able to adhere to all these restrictions and restrictions that were imposed. And so it had a very, very deep, even till now, there's still a lot of struggles with the sex worker communities, even within the KB communities, right? Because a lot of our KP communities retain, other modes of income in the show business and so forth. So a lot of people's incomes were impacted, as well as, their daily livelihoods. There were massive retrenchments across the country in all of those sectors and many more, right? So people's incomes got cut. People did not have jobs anymore. People needed to rely on organizations to step up and step in and be able to assist and help them cope because of the restrictions and also because of the COVID pandemic. So it has been quite a rough patch for us in Namibia, especially with our communities, to be able to pull through these difficult times. So what we did as IntraHealth Namibia is that we applied for a essential services permit with the Ministry of Health, which basically allowed us and many of our partners on the ground to be able to go out there and provide services to our communities. The Ministry of Health definitely, because of the partnership that we have had, saw the need that we needed to continue providing services for our communities because we are left at the periphery of society already as it is. And with COVID, it's an added stigma and discrimination, right? So people felt, ostracized on top of everything that they need to deal with on a daily basis. They had to deal with the possibility of contracting COVID. People were scared of getting into taxis. People were scared of going to malls. Everything was a problem. Apart from that, also having been forced to or being retrenched from your work and having to go back to families that don't affirm you or that don't take you as a human, right? It was difficult times. People did not have communication fees, people did not have food to eat, and because at least if you're working, you could contribute and be welcomed into the household. But the moment that you don't even contribute anything at home, that is another level of stigma and discrimination within the household, right? So there was a lot of those challenges and issues that we had to deal with. We had to do a lot of our work through virtual means because we had to do orientation for the program. It was shortly after COVID was announced that we started the program in the country. So it was quite also not easy having to have all these virtual meetings and also just to ensure that the connection was right and all of those things. So it was quite the new normal for all of us. As I know, globally, it is the same issue. And so with the internet also being strained, there was connection issues because there was no massive network used during the past years, right? So now there was an added problem around the massive use of internet, and so there was internet connections with the trainings, but we continued pushing, and we did orientations with Ministry of Health. We did orientation with our with our partners and projects virtually. We provided PPEs for our communities and organizations in order for them to be able to protect themselves when they go out to provide these services, and also just to ascertain the situation on the ground, right? We had to make pre-appointments with health facilities in order for our clients not to go and sit for long hours at healthcare facilities, just to pop in, collect their medication or collect what they needed and then leave. We had to do orientation meetings on the project as well with the regional staff and the district teams in small due to restrictions were limited to number of 10. So we needed to cut down also face-to-face interaction to 10 and also ensure that we adhere to social distancing and that we were wearing masks and all of those things. We offered services outside the traditional clinics, which meant we had to distribute self-test kits to clients, and we had to do a lot of door-to-door testing as well because of the restrictions and the limitation of movement that was imposed. So we had curfew from 5 in the evening and then till 5 the next morning. So after 5, no one on the ground. The military was on the ground outside. Police were on the ground, so you couldn't be seen in the streets anyway. Even if you're coming back from a hospital, past 5, it was an issue, right? I had an incident where a trans woman called me one night and said she was detained by police, was coming back from the clinic at night or hospital, and they literally made fun of her because of her gender identity, and people were making a big fuss around it, right? So there are all of these challenges and issues that we, on top of everything that we are dealing with as key populations, are also dealing with on top of that. We also arranged transport for our communities that needed to access art and also to access PrEP. So we would definitely provide them with transport to and from their places of living to their clinic and back to where they live as well, just in order to ensure that our program continues and you continuously give support to our communities on the ground. As some of us know, KB STAR stands for Strengthening Technical Assistance and Response for Sustainable HIV Prevention and Treatment, right? So that is our motto, and that is how we have integrated into our systems and the work that we do in order to provide services and also be there for our clients as they need us. And also the clinics also provided with a 3-month dispensation of medication, which also helped people from going to and from clinics and also lessen their time to be able to access services or lessen their time to be able to collect PrEP and art at the clinics. So that would be, yeah, what we have done in terms of COVID in the country and with our communities and K-pops in the country as well. Kent, I can't hear you. Can you hear me?
I'm sorry, I was on mute. I can hear you now. Yeah, okay. It sounds what I was going to say, it sounds similar, going virtual. As I said, a lot of the programs I've worked with, this issue of food insecurity is huge, especially for sex workers. And folks might notice, but recently we've gotten KPs added to the SGAC, to the OGAC PEPFAR guidance on how to respond to COVID. And recognizing KPs are often food insecure as well. And so if folks are adapting programs, it's something that they may look at to be able to provide some food insecurities. So happy to talk about that more, but I encourage you to reach out to AORs or activity managers on that one. Once again, for everyone else, if you'd like to ask questions, be happy to put them in either the chat section or the question and answer. I'm going to move us to our next question. So if we could move the slides. Our next question is really about community engagement. This is a little bit of how PASMA was able to shift its strategies. So can I go to the next slide? Yeah. Susie, I don't know if you want to speak briefly. This looks like what you were able to do, right, with online outreach that you guys were doing.
Yeah,
right?
exactly. Yeah. This is the campaign I mentioned, and the good thing is that you can see how it was adapted to 4 different indigenous languages, Honduras and Panama, and also addresses stigma and discrimination and mental health in addition to prevention messages. But these are some examples of the campaign.
Yeah, PASMA's famous for its social marketing, so excellent. So can we move to the next slide? So our next question is really about engaging communities. And so this is beyond COVID, but the question really is about how does your program engage KP communities successfully in the design, implementation, and evaluation of your program. And on this one, I think I have Tifaranji who's going to speak to this. Also Jorlina and also Susie. So Tifaranji, you want to take us away?
Hello, Kent.
Hey there.
You can hear me?
I can.
Okay, thank you very much. In terms of involvement of the key population in the design, as well as the implementation and the evaluation of the program, at the CEDEP in Malawi, we're looking at the key population. Most of all our programming, we are relying on the key population on the ground as peer educators, peer navigators, and even outreach workers. Now you cannot think of implementing or designing any program without their key involvement. So at CEDEP, even when we are coming up with our strategic plan, as we are doing now, because our 2016 to 2020 strategic plan is coming to an end, and we are developing the 2021-2025 strategic plan. It's the key population are at the center of it all. So you can see how they are involved right away from the beginning. Even when we're developing our proposals, as we are trying to develop the activities, we look at some of the gaps from the projects that we have been implementing. In the case of the Protect, we are coming from EPIC. We had that kind of engagement. Apart from the usual engagement that we have with the peer educators and peer navigators on a monthly basis, when we are implementing our project, we have monthly planning and
Tefranji, you still with us? Can others hear him?
I can't.
Yeah.
I can't.
Awesome.
I think we might have lost him. Sorry, Tefranji. Maybe I can go to Susie. I think you're going to respond to this question as well. Sorry, Tefranji.
Sure. So how we have engaged with KP,
and I'm sorry, just real quick, we have a slide on this one, right, Susie?
Yes, we have a slide.
Yeah, so why don't we switch to the next slide as well?
Okay, thank you.
Which will help you.
So, you know, we work close with key populations and we try to involve them in all the process, in the design, implementation, and evaluation of our program. And when designing, one of my favorite exercises is working through the EIP process. EIP is a methodology that follows the human-centered design methodology and means empathy, insights, and prototyping. It involves multiple key actors to design an intervention. For example, in Panama, we conducted an EIP workshop with people living with HIV, but not only with them, making them part of the design, but also involving their family, partners, you know, healthcare providers, on topics of treatment and adherence. The Ministry of Health was there, other NGOs. So like all the key actors that participate in the process. It was an opportunity to review existing evidence, discuss, listen, co-design the adherent intervention in close collaboration with all participants. And what is exciting about this methodology is that you hear from and work with, not only with the target populations, but also with other persons that influence their decision making. And so that's the way we involve key populations in the design part. In the implementation, cyber education is an important intervention that really engages key populations because it's a two-way and a constant communication. rarely ends with just a referral on HIV testing. There is ongoing communication for follow-up, to ask questions, to advise on next steps, to reach out again after a test, to solve doubts or know what to do next. So cyber educators become like a close health advisor or that person that you can reach out to constantly to build a relationship and ensure ongoing health. And we also work in close collaboration with key population organizations, associations, community groups. There are cross referrals, joint efforts, multiple opportunities to work together. For example, now with all the COVID-19 situation, we collaborate in specific activities, like for example, delivering adherence kits during COVID-19 through these other organizations. And finally, in the evaluation process, in addition to collect data from key populations, PASMO implements a strategy that involves them in the interpretation and analysis of research and monitoring results. And more importantly, in the development of programmatic decisions and interventions based on that evidence. In summary, our project, the new project that we are just starting, is working and has like a main objective of building community, addressing integral health beyond just an HIV test, but other needs that help build and strengthen key populations communities.
Thanks, Susie. I think the struggle we often have is that needs of KPs are much greater than just HIV. And yet our agenda, our PEPFAR agenda, is an HIV agenda. And so I'm curious, it sounds like Tifaranji, are you back with us? Tifaranji, you back? Actually, if we can bring the slide set back 2 slides, back to the question.
Yes.
So Tifaranji, keep going. But I'm curious if you can respond to, those other needs, yeah? KPs often have greater than just an HIV need, and I'm curious, through community engagement, how those other needs are addressed by your program.
That's true, Kent. We have a very big challenge in terms of failing to address most of the needs of the key population, considering that our programming, HIV programming, predispose the community members to stigma and the discrimination, apart from even human rights violation, gender-based violence, because of the perceived sexual orientation. And in Malawi, looking at our laws that are still punitive in nature, still it's very challenging in terms of considering that the projects do not deal very much with the structural barriers that are existing within the community. The HIV programming very much is emphasizing on testing, getting people linked to treatment and having them their viral load suppressed. But at the community level, the peer educators, peer navigators are exposed to a lot of stigma for the work that they are doing. That's one of the biggest areas. And we have in some way managed to work on the structural barriers by having some other parallel projects under our advocacy department. We had project Access to Justice. We're working with the police and working with the community traditional leaders as well as religious leaders. But still more are how many people did we reach out to? And looking at the project itself had its own as well areas, catchment areas. So that's one of the biggest challenges that we are having as we are implementing HIV and we predispose the community. And some of the peer educators are young, are staying with they are in their early adulthood, 19, 20, 23, but still staying with their parents, dependent on their parents. Once they are known that they are of this sexual orientation, that even they are chased from their houses. Those are some of the challenges that we are faced with as we are implementing the HIV and AIDS programming.
And are those structural interventions, are they funded by PEPFAR or are they funded by other donors? Or both?
Currently PEPFAR is not funding, it's funding partly the part of the police orienting the law enforcers, so that in terms of one being victimized, the police are knowledgeable in handling cases, in the sense that one should not be victimized because they are of a certain sexual orientation, but because they are a human being responding to human rights as Malawi enshrined in our Constitution, Chapter 4, all have to be protected regardless of who they are. So that area we are tackling it.
Great. So I think Joe Lorena wanted to speak to this question as well. And I'll be honest, panel, we've got about 10 minutes left. So Joe Lorena, if you can be brief, because I've got one more question for folks to answer. So we're talking about community engagement, how you involve community in program design, development, implementation.
Okay, so I will definitely be short and brief. So basically what we have done is from the onset of the design and development of this project, we've engaged key populations, right? So from the beginning, the design and the development of this project is with the input and commitment and contributions from the key populations. Secondly, one of our 3 project goals is capacity development, right? So we have been able to work with our KP organizations to be able to capacitate them in order to be able to prime recipients moving forward, to move from the current fixed grant to a corporate grant and eventually become a prime recipient. So we are actively working on that and assisting them, literally physically being there and accompanying them to different facilities in order to get their documentation in place and so forth. We have bi-weekly review meetings with all the partners, which it identifies innovative ways of doing our work, and also providing services to our communities. We do have monthly M&E and finance verifications, which are conducted for strengthening the M&E systems and finance systems for our partners. We also do joint trainings for all partners to build stronger partnerships and for ownership purposes. We do quarterly program review meetings to enhance programming and target achievements. And also finally, we do regular communications to KB-led organizations to strengthen partnership. And also we have an open door policy. So whenever there are issues, they would usually just walk up here and say, we are unhappy with A, B, C, and D, and we'll take it from there. So there is ongoing conversation and engagement. It's not perfect yet, but we are definitely working on those challenges and issues. As you have said, Kent, yes, our communities have further needs apart from what we are currently offering on this grant. And I think USAID is providing Wild Fish Corridor Group with some essentials, which are soaps and cleaning materials. We have engaged our AOR on nutrition support, and we are still in engagement. Hopefully by the end of this month or in the middle of this month, we'll get a response in order to be able to provide those services for our communities. Yeah, I will be short and brief on that. Thank you.
I mean, one of the things I'd add is that, by funding KP-led organizations, you're able to help them also diversify their funding base, so that if PEPFAR is funding them to do testing and treatment, someone else might be able to fund them to do SDI work or homelessness work, or, you know, and so there's a way to help strengthen that organization, to help realize we're going to meet the structural needs as much as these biomedical needs that our programs have. Yeah. So I'm going to have to move us to our final question. Yeah. So if we can, I think it's two slides down. So this question's really about, as a local partner, what are the capacity needs that you guys might have? And I think for this one, I've got Michael, and then I've got Tifaranji to respond to this. So I think the question was, you know, what current capacities needs do you all have in terms of strengthening? Michael, you want to respond to that?
Yeah, thank you very much, Kent. For us, I think basically as a local-based organization, we need to tell our story. We need to be able to tell our story in a way that is compelling. So for us, we will actually need support in how to tell our story. And why that is very important is that we work with key population. In Nigeria, some of them are criminalized. And we want to tell our story in such a way that it portrays the truth about the community and what we also do with the community. Heartland Alliance as an organization, basically it's more of, everything we do is with the community itself, from the implementation at the community level, from the design of our project, the implementation of our project, the evaluation of our project. Every part of our project implementation is basically key population. And we want to be able to tell these stories. We want to be able to talk about our innovations. We want to be able to produce things, animations. We want to be able to produce stories that actually convey our story, so that these will also have an impact on the community itself, that yes, they are also doing an amazing work, and also on the part of Heartland Alliance too.
Thanks, Mike. Tifaranji, and actually we've got a question that came in, Tifaranji, I don't know if you can respond to, specifically about our you know, in Malawi, and also Nigeria. Michael, you can answer later. You know, is most of the work being done by KP community organizations, or there are others doing KP NGOs?
Yeah. In Malawi, it's KP organizations. We have had international organizations supporting the KP-led organizations because of, in terms of the capacity out there. But as we are, like SEDEP as well as Bakachele have been roped in to implement, to get support directly from USAID.
And Pakacheri is a sex work organization, is that correct?
Yes, sex worker organization. So that is now what we are experiencing, that the capacity of us local organizations has been built by the international organizations such as FHI 360.
Sure.
Yes.
Yeah.
In terms of our capacity.
Please, Tifaranji, yeah. Mm-hmm.
Yes, yeah. I'll quickly go to being local organizations. The challenge that we are buffered with the catchment areas that we work, issues of transportation. We do not have our own vehicles, and even the grants themselves for us to say we'll procure a number of vehicles to support the implementation. That's one of the biggest challenge we have. But also I want to agree with Michael. We need to tell our own story. That is very important. If we have specialists that are good at documentation, we have a lot that we are doing, and we are unable, because of our capacity, to tell the story and put it in the way that it is appealing and people can understand the situations or the work that we are doing as compared to other international organizations. And lastly, the areas of, for us to be able to tell a story, we have to have a sound and robust M&E system. That's one of the biggest areas to show and demonstrate the work with the evidence. So if we can be built in these areas, I think we are ready to go.
Yeah, Tefranjay, I agree fully. I think being able to report for PEPFAR, which is quite challenging at times, is vital, because our folks are going to come back and say, if you're not reporting, we're not showing success, why are we funding this group? Mike, I don't know if you want to respond. And we had one question about trans folks. If folks are, what experience do you have in working with transgender populations? Do you work directly with trans associations or NGOs? Can you respond to that one, Mike? Yeah.
Yeah, for us, we work directly with trans association and NGOs in all our projects. Presently, that we work in 3 states, we have 3 trans-led organizations that are actually providing community-based intervention for trans persons. And as an organization, before we transition into a local organization, when we are still working with Heartland Alliance International, there was an innovation fund as far back as 2015 that actually came, and that actually supported us in working with the first trans organization in Nigeria that were able to build their capacity. And from there, we've been able to move to 3 others presently. So basically, Heartland Alliance work with KP-led organization. All our implementation, just like I've said, at the community level are with KP-led. Female sex workers, men who have sex with men, trans persons, persons who inject drugs. All of them that we work with are actually KP-led. So as an organization, that is our philosophy. And apart from that, we don't just work with them for implementation. We actually go further to build their capacity also. So basically, there's a skills transfer to this organization and capacity building, both individual capacity building and organizational capacity building.
Yeah, that's great. So it looks like we are out of time, but I really want to appreciate everyone who attended, as well as more so our presenters. A lot of you are working very hard out there to do work, especially with COVID restrictions, and so we appreciate all of that. Thank you very much, and I think that's our time is up. We're about to be kicked out is what's going to happen.
Thank you, everyone. Thanks, Kent, for this great moderation. Thank you to the panelists, and thank you, Sonia, for taking notes. It's been wonderful. Muchas gracias a todos. Merci.
Thank you.
All right, bye, guys.
Bye, everyone.
Bye.